Welcome back to Corium. I'm Brian Gilberti, and today we're joined by one of our brilliant senior residents, the one and only Chris Pham. Welcome to the studio, Chris.
So happy to be here, Brian.
Okay, so let's get to it. Today, we're going to be tackling a beast of a topic, which is pneumothorax, and it's something that we see somewhat frequently in the emergency department in a lot of different settings, whether it's underlying lung disease or trauma. So we want to touch on the topic here, and we also want to keep an eye on the data and the numbers so we get a better idea of how we should navigate the management of these patients and how we should view our diagnostics when we use them. Now, Chris, why don't you set the stage and start us off with a case?
Absolutely. So I had a 50-ish something male with a history of asthma. That was just about it. Said that he had been feeling a bit short of breath for the past few days. Said it felt pretty similar to prior asthma flare-ups. He uses his albuterol MDI as needed. He's not on anything standing. It's never been a really bad issue for him. And today just decided it's too much. The shortness of breath has really gotten to me. I'm going to call the ambulance. Ambulance comes in. They agree. They think the guy has an asthma flare-up because he's telling them that he has an asthma flare-up. They give him some nebs en route, bring him to our triage nurses. They listen to his lungs, agree, sounds like an asthma flare-up, and bring him back to the ER. I go and take a look at him really quickly because asthma flare-ups can certainly be very scary, as I'm sure Brian will have another podcast about at some point. And his vitals are fine. He's not hypoxic. He's not tachycardic, not tachypnic, and normotensive. I go and speak with him. He's not using any accessory muscles. He's speaking in relatively full sentences. And you take a listen to his left lung and you hear very little, which could be a sign of a really bad impending asthma flare-up if they're very tight. But that didn't really look clinically like what was going on. He looked a little bit too comfortable for that bad of a asthma flare-up. You go and listen to the right side of his lungs, though, and sounds clear as a whistle, which does not really fit with an asthma flare-up. You start talking to him a little more, and you find out that he had actually fallen out of bed just a few days ago, landed on his chest, and his chest has just been hurting him very focally right there for the past few days. You actually put your hands on him, you feel some nice Rice Krispies, some crepitus, if you will, and you realize this guy doesn't have an asthma flare-up. It's a pretty simple pneumothorax.
Excellent case, Chris, and it really illustrates that there are going to be a lot of things on this differential when they come in. So let's zoom out for a second. Who's actually at risk for pneumothorax, and what are the big risk factors we have to keep in mind?
So great question. Theoretically, everyone is at risk of a pneumothorax, but there are two big buckets that you first classify people into. They can be either primary pneumothoraces or secondary pneumothoraces. Your secondary pneumothoraces happen secondary to some inciting event. More often than not, it's trauma, someone who has sustained some rib fractures, falls on their chest, like our patient, and has a pneumothorax, and anyone is susceptible to that. You also think about your iatrogenic secondary pneumothoraces. So patients that are getting central lines placed, pleural effusions drained, thoracentesis, any sort of proceduralization in the thoracic cavity or near the thoracic cavity. Sometimes the provider will go just a little bit too deep, nick the lung, and get a little bit of an air leak that causes a bit of a pneumothorax. I think the more interesting side of this is the primary pneumothoraces. These are your pneumothoraces that happened without any necessarily outside inciting event. And the people that are at risk of these are for your spontaneous pneumothorax, where there's really no underlying disease. Those are your younger males, like ages 10 to 30, that are young, tall, skinnier. You can also think about patients with connective tissues disorders like Marfan's, Ehlers-Danlos, and then those that have underlying lung disease like COPD, bullous disease, interstitial lung disease, cystic fibrosis, tuberculosis, what have you, malignancy. So those are going to be the patients that are more predisposed to having a pneumothorax just spontaneously develop without any outside inciting event.
Perfect. Now let's talk about symptoms and differential. When someone rolls in short of breath with chest pain, what else stays on your list? And Chris, tell us about the red flags that push you towards tension physiology.
Absolutely. So the differential in the ER is going to be extremely broad for someone that comes in with the generic signs of a pneumothorax, which is just going to be dyspnea, some shortness of breath, maybe some chest pain. So you're going to think about your lungs first and foremost. You're going to think about pneumonias. You're going to think about hopefully pneumothoraces, any sort of reactive airway disease like your asthma flare-ups, COPD flare-ups, someone maybe with some underlying interstitial lung disease, some sort of weird infections, your pulmonary edema patients, patients with SCAPE, your flash pulmonary edema. And then you also got to consider cardiac as well, especially if they're complaining of chest pain like our patient was. So ACS, CAD, some sort of valvulopathy, a CHF exacerbation, the differential is huge. And then to answer your second question about what signs and symptoms you're looking for the most part, they're going to be relatively nonspecific. A lot of your money's going to come from a good history and a good physical exam. But in general, they're probably going to just tell you, my chest hurts a little bit. It hurts when I take a deep breath. Usually it's going to be a little bit more focal if there was one traumatic site of where the traumatic pneumothorax happened. But if it's not a traumatic pneumothorax, you may not get that focal site. Some dyspnea, of course, some shortness of breath. And then exam-wise, you're going to be looking for decreased breath sounds, theoretically unilaterally. You're going to look for, in your more severe cases, your red flag symptoms, signs of a tension pneumothorax. It's going to be stuff like JVD, tracheal deviation, which is a pretty severe sign of it. You're going to look at your vital signs. That's one of the first things I look for whenever a new patient pops up on my board, whether I need to go see them immediately, or if I have time to let my juniors go and see them first. So if they're hypoxic, if they're extremely tachycardic, tachypnic, hypotensive, I'm definitely going to be getting up and seeing them immediately.
Okay, so let's say we're pretty sure we're dealing with pneumothorax. Walk us through the workup. What tests matter? What's optional? And what's just noise in the emergency department?
Sure, totally. In the ER, like you were talking about earlier, we have to keep our differential very broad. As far as we know, this patient just came in with shortness of breath. We're thinking most likely pneumothorax, but we're still thinking about our ACS, our pericarditis, our PEs, what have you. And that's going to vary depending on the presentation. Sometimes they're just going to be screaming pneumothorax. Sometimes your PE may still be a little bit higher on your differential than you want. And so that's going to guide a little bit more of your serology. I think a lot of these patients are going to come in and they're going to get an EKG to begin with just because they're short of breath. Very easy, cheap, non-invasive test. And then as far as your blood testing goes, blood testing isn't going to be super helpful for your pneumothorax necessarily. The main thing that you're going to be looking for is a type and screen and a recheck in case they need to have some sort of proceduralization done, in case there is a hemothorax that we're working with. But other than that, not too much blood work that's really going to help us out with a pneumothorax. Of course, if you're still concerned about ACS or PE, maybe you're going to get that trope or dimer or a BNP, but none of those are really going to be driving your pneumothorax workup. So first things first, like we said, or we were just talking about, we always have to keep the differential broad, even if we're 80, 90% sure this is a pneumothorax, but we still need to rule out stuff like ACS, PEs, et cetera, et cetera. But beyond serology, a lot of the money for pneumothorax is going to come from imaging. And you know that in the ER, all of us ER docs love our ultrasounds. Everyone's got one strapped to their side like a little holster. But yes, point of care ultrasound is going to be one of our first quick adjuncts that we can use in the ER, especially if our clinical suspicion for pneumothorax is really high. And there's actually a lot of good data and studies out there that show that the sensitivity and specificity for ultrasound is really good, especially in comparison to what's classically thought of as a, not gold standard, but the first line, which is a chest x-ray. So chest x-ray sensitivities range from 70 to 90% for small pneumothoraces, and you might see that pleural line, your hyperlucency, but ultrasounds can have a bedside sensitivity of 86 to 96%, depending on the operator, and specificities as high as 97 to 100%. But again, a little bit operator dependent. As far as what you're looking for on an ultrasound, you're going to be looking for your seashore sign, which is when you find your pleural line, put your M mode on, and you see this nice gradient of hyperechoic lines going into the background. That's a sign of good lung sliding. And then if you don't see lung sliding, you're going to see that barcode sign, which is very satisfying to see in real life. And then the most specific sign that you're going to be looking for is going to be what's called your lung point. So you're going to look for your pleural line, you're going to look for those ants crawling on a log, and then you're going to see continuation of that pleural line, but all of a sudden it's going to be static. No ants crawling on that log. And that's your most specific sign on ultrasound for pneumothorax. That's going to be our first line imaging in the ER to really point us towards which trajectory this patient's going to go down. And it's going to be very helpful for helping us figure out, is this a pneumothorax? But if it does come back positive, we are still pretty sure this is a pneumothorax, assuming we have a little bit of time to get a little bit more workup. Most of the time we're going to be getting a CAT scan, which is the true gold standard. And there's a few reasons for that. One, we want to see the severity of the pneumothorax. We want to see just how big of a thorax we're dealing with. Is it something that we can really stick a tube into and actually do an intervention on? We also want to make sure that this truly is a pneumothorax. One of the worst things you can do is say this is a pneumothorax, not get imaging, stick a needle in it, and then realize later that you stuck a needle into the lung parenchyma, into a giant bulla. And you also want to see if there's other stuff in the chest that's not supposed to be there. Obviously, the air isn't supposed to be there, but you want to make sure that there's no blood, no pleural fluid, something that would push you towards a maybe larger bore chest tube or some other more specific intervention to evacuate all those contents.
Love it, Chris. And now time for the money question, which is management. CT can help size and characterize things, but at the bedside, how do you decide who gets just oxygen and is observed and who needs a needle or a tube right now? And walk us through the decision tree that you use.
So if you're going to be doing an intervention on pneumothorax, you're going to have some upstairs person that's going to be accepting this patient. Most of the time, you're going to be putting a tube into these patients' chest, and you can't send someone home with the tube in their chest. So a lot of this discussion is going to happen with whoever your admitting service is, what kind of tube they're comfortable with, what kind of intervention they're comfortable managing in the upstairs floor. But as far as the ER goes, assuming that you're in a vacuum and there's really not someone else that you need to admit to, the first decision point that you have to go through is this someone that needs a tube or not? So in very small pneumothoraces where they're less than 2 centimeters while they're on oxygen, you might be thinking maybe I can get away with just conservative management with just oxygen. Your first line treatment for any pneumothorax, or really anyone that's hypoxic, is giving them some oxygen and seeing how they respond. In pneumothoraces in particular, there's some physiologic reason, some science behind actually putting them on 100% non-rebreather to help them resorb all that intrathoracic air. So really easy thing to do to start your management of a pneumothorax patient. And then the big decision point after that is going to be stable versus unstable. So if they're unstable, if they're showing signs of shock, tension to physiology, and you really don't have time to gown up and put a nice chest tube or pigtail in there, you're going to be doing the TV show thing of a needle thoracostomy. You're going to grab your largest bore angiocath that you can, usually like a 14 gauge in an adult. You're going to go intercostal space 2 around mid-clavicular line, put that angiocath in as about 5 or so centimeters, try to get that gush of air. It's not going to be your definitive management, but it's going to hopefully give you a little bit of release of that air, buy you some time so that they don't potentially arrest on you. Once you temporize them and they're stable to actually get their more definitive treatment, you're going to be deciding theoretically with your inpatient team, is this person going to need a large bore chest tube, like a surgical chest tube, or a smaller bore pigtail catheter? Now, Brian, if I'm ever in the ER and I have a little spontaneous pneumothorax, I'm going to be asking you for that pigtail.
Copy that, message received, Chris. We'll holster that 50 French rooter of a tube that we have set aside for you, and we'll just reach for a pigtail if you come in with a straightforward pneumothorax. But beyond your personal preference, Chris, tell us more about why we should be reaching for pigtails in our simple pneumothorax.
It's a much more comfortable patient experience compared to the large bore. It's a smaller tube, it's much less invasive, and there's actually good studies out there showing that it is just about as effective, if not more, than your large bore chest tube in simple pneumothoraces. Now, we're not talking about your patients with the really large ones or that have other gunk in the chest like blood or empyema or pleural fluids. That's when you might be considering more your large bore chest tube.
All right, they're stabilized and we've done what we need to do. Where do these patients land? ICU or the floor, and who typically owns them in the hospital?
So they're going to be admitted, more than likely. You're going to have some sort of chest tube placed in there. You can't send someone home with a chest tube sticking out of their chest. And then as far as where they actually go within the hospital, that's going to be hospital dependent. You're going to want to talk to whoever your hospital deems is the person that manages pneumothoraces, whoever is comfortable with managing chest tubes, pigtails, what have you. For us, more than likely, that's going to be our trauma service, because a lot of our pneumothoraces that we see are traumatic in nature. But sometimes in your non-traumatic cases, you can be talking to your cardiothoracic surgery team, your medical ICU team, sometimes your medical floors, although I don't think that our medical floors are comfortable managing chest tubes just at our particular institution. But that's going to be hospital dependent. And then the next question you have to ask is, how stable are they? Do they need a higher level of care? Do they need to go to an ICU? And that's going to depend on how dynamic their course has been in the ER. Have they been just chatting with you the whole time? And were they surprised to find out that they had a pneumothorax and they needed to stay? Or has this been a roller coaster? Are there angiocaths sticking out of the front of their chest? Have they been hypotensive? Were they intubated? Is there some reason that you need them to be monitored a lot more closely for the next 24 to 48 hours? And a lot of this is going to be in discussion with your upstairs consultants, and they'll help guide you to where this patient actually needs to go.
Perfect, Chris. That was really gold. And before we wrap up, let me hit on 5 take-home points for the listeners. First, as always, don't anchor unilateral decreased breath sounds, plus minus pleuritic chest pain, especially with recent trauma or procedures, should make us think pneumothorax along with the usual suspects like asthma, COPD, ACS, PE, pneumonia, and the list goes on. POCUS is going to be your friend here. It's fast and it's sensitive. Absent lung sliding, barcode sign helps. Lung point is highly specific. And use chest x-ray for a quick, somewhat quantitative evaluation, but reach for your CT for additional data points like the size of the pneumothorax and to help us characterize or exclude a hemopneumo. Next, treat physiology first. Oxygen early. If they look like tension, which is hypotension, severe distress, JVD, then decompress now, whether that's with a needle or a finger thoracostomy per your training. Then move to definitive tube or pigtail and use the right tube, use the right tool. If they're stable, small pneumothoraces can often be managed conservatively with oxygen and observation. For simple air-only pneumothorax, small bore pigtails work well. Reserve the large bore chest tubes for blood, viscid fluid, or big traumatic injuries. And finally, plan the landing. Disposition depends on stability, trajectory, and your institution's comfort with tube management. And you want to loop in the receiving service early, and don't forget to reassess often. Okay, that'll do it for this episode. Chris, thanks for joining us.
It's been so great. Thanks, Brian.